presentations. اتفضل يا دكتور ممدوح. اتفضل يا دكتور ممدوح.
بسم الله. حاضر يا فندم. السلام عليكم.
عليكم السلام.
ان شاء الله النهارده هنتكلم على بيوجينيك سبونديلوديسكايتس. طبعا بدايه بشكر استاذ الدكتور جلال استاذي ومعلمي، واشكر الدكتور اشرف اسماعيل استاذي طبعا ومعلمي، والدكتور محمد الاشرف رئيس القسم، والدكتور احمد الشيخ، وبشكر كل زمايلي في القسم، وبشكر الدكتور مصطفى سعد الحقيقه اللي هو ساعدني في تحضير البرزنتيشن. ان شاء الله نتكلم عن موضوع في غايه الاهميه، موضوع سبونديلوديسكايتس. Spinal infection are basically divided into two types, biogenic and non-biogenic, which is called also granulomatous. Spondylodiscitis is infection of the intervertebral disc space. Vertebral osteomyelitis is the infection that invades the end plate of the vertebral body. How many infections? There are 3 to 5% of all cases of osteomyelitis. Biogenic
دكتور ممدوح.
الصوت يا شباب.
الصوت يا دكتور ممدوح.
دكتور هشام شاكر. دكتور جلال باشا.
ايوه يا بيه.
الدكتور هشام شاكر معانا دلوقتي يا فندم، نرحب بيه.
اهلا وسهلا. احنا نرحب بيه ترحيب كبير جدا.
ماشي نكمل.
اخونا وصديقنا العزيز.
اتفضل يا دكتور ممدوح. اتفضل يا باشا.
The commonest mode of spread is hematogenous. Retrograde blood flow from the pelvic venous plexus to the vertebral plexus. طبعا pelvic لو كان في lumbar spine, thoracic venous plexus in the thoracic spine, and cervical venous plexus in the cervical spine. Other mode of infection or spread of infection is direct inoculation or spread from the adjacent areas. The lower thoracic and lumbar. In the children, this remains up to 7 years, allowing primary inoculation. Or the high-risk patients who has septic focus in the skin or genitourinary tract, or by invasive procedures, or in the immunocompromised patients, like patients with tumors, or patients with HIV, in the diabetics, patients who use continuous steroid treatment, or in spinal surgery. The most common organism in the spinal infection is Staph aureus in 50% of cases, followed by gram-negative, like E. coli or Proteus or Pseudomonas. Pseudomonas was prevalent in the drug abusers. Proteus present in the urinary tract infection. Then the last infection organism is the anaerobic infection. Clinical presentation: non-specific back pain, unremitting pain. It is the first presentation feature. Pain more at night, Constitutional symptoms like anorexia, night sweating, low-grade fever is less common, but more with TB of the spine. The most common sign is tenderness at the affected site, sustained paraspinal muscle spasm. Complication presentation is neurological deficit, epidural abscess compressing the cord. Presentation in children before 3 years of age, the presentation was mild, irritability, refusal to bear weight, limping gait. Between 3 and 10 years, back pain, fever, abdominal pain. After 10 years, the presentation is back pain, localized tenderness, and rigidity. Laboratory investigations in biogenic spinal infection, elevated C-reactive protein. It is more sensitive marker, the peak within 2 days of surgery. If the infection was post-operative, it has rapid fall. Elevation even after a week of surgery suggests infection and rapid decline with treatment. The ESR is elevated in 70 to 97% of patients, especially in the children with discitis. Generally, it's more than 50 millimeters per hour. Peak at 5 days and elevated for 4 weeks. Presented elevation after surgery, suggestive of infection, remains high after treatment for prolonged period of time. The leukocytic count is least useful, elevated only in 30% of cases. Blood cultures should be obtained in all cases, especially during febrile period. Aerobic and aerobic blood cultures isolate pathogen in 30 to 78%. Radiological evaluation. Plain X-ray, it is a primary investigation of choice. Mutation of grade goes up to 6 months, 30% of bone function required to show the pathology. Findings in plain X-ray: number 1, reduction of disc space, erosion of endoplates, destruction and collapse of vertebral deformity, resulting in the deformity. CT scan, early detection of infection, but cannot detect the subchondral marrow changes. Findings in CT scan: circumferential paravertebral soft tissue involvement, gas within bone, disc space narrowing, and diffuse bone destruction. MRI, the modality of choice. Marrow signal alteration by exudate and edema in the earliest radiological finding by MRI, much before appearance of radiological changes. In T1, it is hypointense. In T2, it is isointense. And STIR, hyperintense, this type of fat suppression. Contrast MRI. MRI with IV gadolinium. Homogeneous enhancement in paravertebral or epidural soft tissue. Useful post-operative spinal infection. The possibility of post-operative infection is considered when there is new erosion of the endoplate, osteolysis, marrow edema, intradiscal or epidural abscess, with migrated hardware for in the infection of the fixation with fixation, and peri-implant collection with loosening of the screws. Nuclear imaging, radioisotopes, early detection of infection within 48 hours with technetium-99 diphosphonate, CT SPECT, gallium-67 citrate and indium-111 labeled, useful in pyrexia of unknown origin, shows increased uptake at site of infection. Biopsy, best method for determining the infection. CT-guided biopsy, it is minimally invasive and it should be used in the cervical spine. Open biopsy, if blood culture and percutaneous biopsy fail to identify the infecting organism. Assessment of response to treatment by imaging studies. Radiographic features of healing. Progressive sclerosis, fusion of affected vertebral bodies, and deformity. MRI finding of healing, restoration of marrow edema, fatty replacement of marrow, and resolution of cord signal changes and the paravertebral epidural abscess. MRI evidence of healing lags behind the clinical improvement by 2 months, so must be used after 4 months. If MRI shows deterioration beyond 6 months, it is a refractory case. Differential diagnosis of spinal infection, biogenic spinal infection. Number 1, modic type 1 end-plate changes in degenerative spinal diseases. Concentric smooth subchondral marrow abnormality within an intact cortical end-plate. Well-defined linear demarcation between normal and abnormal marrow and modic changes. The second differential diagnosis, which is important, is malignancy. Isolated collapse of vertebral body, usually relative sparing of disc and lack of soft tissue abscess. So we can say good disc is bad news and bad disc is good news. Differential diagnosis, we continue with the differential diagnosis. Number 3, neuropathic spondyloarthropathy, which is called Charcot spondyloarthropathy, due to cord injury or syringomyelia or in diabetes mellitus. Disc space loss, marginal osteophytes, vacuum phenomenon in disc by CT. Number 4, Anderson lesion of ankylosing spondylitis. Discovertebral region secondary to inflammation, stress fracture, mechanical failure. In the MRI, there is irregular signal intensity changes with lack of soft tissue involvement. CT scan, we will find sclerotic changes on either side of lesion and bamboo spine. Differential diagnosis of biogenic spinal infection with granulomatous spinal infection, and the most important infection is tuberculosis. If we compare or make a comparison between the tuberculosis, tuberculous spinal infection and biogenic spinal infection, as regards bone destruction, the destruction is more severe in tuberculosis. The vertebral body involvement is solitary in tuberculosis, and there is skip lesions, and there is collapse of the vertebral body. The disc space in tuberculosis is relatively spared or late involved with late involvement, but in the biogenic infection, there is early destruction of the disc space. Deformity is symmetrical in tuberculosis, but with kyphosis in biogenic infection. Soft tissue or paravertebral collection is prevalent in tuberculous spinal infection, 95%, but is less in biogenic infection, it is 25%. Subligamentous spread is more in tuberculosis than in biogenic infection. The CT finding in tuberculosis is more common calcification, which is specific for tuberculosis, with bone fragment within lytic lesions, sclerotic margin, larger end-plate erosion. Differential diagnosis with brucellosis. Brucella, which is prevalent here in the Middle East, especially in the North Africa, like in Egypt and Libya, also in Saudi Arabia and the Gulf countries. Brucella melitensis, it is a causative organism. It present in consumption of unpasteurized milk and soft cheese made from milk or infected animals, or in people manipulate the excreta of the animals or the soft tissue of the animals, like in the husbandries, السلخانة يعني والناس بتتعامل مع اللحوم. Symptoms of brucella is presented with polyarthralgia, night sweating, anorexia, and headache. Psoas abscess is found in only 12% of patients. It's specific for the lumbar spine, which is the most common region in the spine which affected, because it is GIT infection. Radiology of Brucella. Prediction in the lumbar spine, as we said, entered the vertebral architecture despite evidence of diffuse vertebral osteomyelitis. Deformity is rare, smaller paraspinal abscess, passage joint involvement. The diagnosis is confirmed by Brucella tetr more than 1/80. It's treated by antibiotic, specifically the tetracycline or the oxycillin, and the antituberculous drugs like rifampicin for 4 months, and monitored by the Brucella tetr and ESR and C-reactive protein. Management of biogenic spinal infection. It is multidisciplinary approach. Conservative treatment in vast majority of cases include antibiotic and limitation of physical activity with brace or without brace. Duration of the treatment 6 weeks for staph and 8 weeks for MRSA. The second line of treatment is surgical treatment with absolute indication if there is neurological deficit, progressive neurological deficit, or with the spinal instability or associated sepsis. The relative indication for surgery is failure of conservative treatment and severe intractable pain. This article proposed a new classification for treatment of biogenic spondylodiscitis, and they adopt in this article the AO principle of classification with type A, B, and C. Type A is less severe, type B is potentially severe, and type C is extremely severe affection in spondylodiscitis. The classification criteria in this article with primary criteria stressed on bone destruction and epidural abscess, and secondary criteria is segmental instability, neurological impairment, and involvement the paravertebral tissues. Type A, spondylodiscitis, A1, A2, A3, and A4. A1, simple discitis, one entity, discitis. A2, discitis plus vertebral body affection, 2 things. A3, 3 things affected, discitis, vertebral body, and soft tissue. A4, all of the above plus intramuscular abscess. Treatment of type A is rigid orthosis, type A, 2, 3, and 4, rigid orthosis with or with percutaneous stabilization. If the rigid orthosis is not tolerated, we can fix the spine percutaneously. Type A spondylodiscitis, non-operative treatment, 24 hours daily for daily embolization with rigid orthosis until complete infection healing. The second choice is posterior percutaneous screw rod instrumentation, bridging the infected level in patients with single level thoracolumbar spinal infection with functional demands. The second article talk about the comparative study between the posterior percutaneous screw rod instrumentation in comparison to the thoracolumbar spinal orthosis, rigid bracing for single level biogenic infection. The results of this article: all patients improve markedly with antibiotic therapy, ESR and C-reactive protein. Both treatment groups mirrored clinical improvement. And the the big message of this study is no statistically significant difference were observed between both study groups. Surgically treated patients had lower VAS score at 1 or 3 months. Surgically treated patients showed higher mental and physical scores, SF12 at 1, 3, and 6 month follow-up. Type B spondylodiscitis. Here we talk about potentially severe infection of the spine. Type B, beginning with B, bone destruction. Bone destruction only, B1, bone destruction. B2, bone destruction plus paravertebral soft tissue. B3, three things, bone destruction plus instability and segmental kyphosis. Treatment, B1 and 2, rigid orthosis or percutaneous stabilization. B3, as above, plus may need open stabilization for segmental instability and kyphosis for correction of instability. Type C is spondylodiscitis. C1, here epidural abscess. For easy learning, we can call C1 collection of pus. The C1 collection of pus. C1 only pus collection. C2 collection plus segmental instability. C3 collection of pus plus acute neurological impairment without instability. C4 pus collection plus neurological deficit and instability. Treatment of this severe type, C1 orthosis or percutaneous with close clinical and radiological monitoring. C2 open debridement and stabilization for segmental instability. C3 open debridement plus decompression if there is in this type C3 if there is neurological deficit, so we have to do decompression. C4 open debridement plus decompression and stabilization. Take home messages. Early diagnosis is based on high level of suspicion with emphasis on patients presenting with acute and localized spinal pain combined with fever and high risk factors for infectious disease. We have to identify the cause of infection by asking for chest X-ray for chest infection and echo for heart cardiac infection, endocarditis, and urinary tract infection, culture of urine, blood culture, MRI, whole spine for skip disease metastasis or skip lesions. Contrast enhancement MRI, high diagnostic sensibility, allowing to detect impending neurological lesion or structural damages. When there are no neurological deficits and no significant instability, pyogenic spinal infection managed with rigid orthosis. Percutaneous post-screw fixation, safe and effective alternative to orthosis for single-level thoracolumbar spinal infection, also mild instability and mild segmental kyphosis, never for cases of neurological impairment. When acute neurological impairment or severe kyphosis, surgical approach is mandatory. Pyogenic spondylodiscitis is still burdened by significant mortality complication rate. Diagnostic delay is the main prognostic factor. Thank you. شكرا.
شكرا دكتور ممدوح لي. Thank you so much Professor ممدوح الكرماني for this very interesting talk. أستاذنا دكتور جلال بيه سعادتك معنا؟ دكتور أشرف باشا.
Thank you very much, Professor Mamdouh, for this very enlightening lecture, actually, which have shown the modern techniques for management of infective spondylitis and ascites. I would like just to say a few points. Presence of high fever and rigors accompanied by urinary tract infection and severe tenderness over the back is present in cases of acute non-specific ascites or spondylodiscitis. We have to bear in mind in our region for the presence of brucella and typhoid cases. By doing the routine investigations for laboratory investigations, ESR, white cell count, CRP, anti-brucella titers, and Vidal tests. This will give us ability to catch such cases, which are not very common, but they are present. I usually see about 2 or 3 cases every year from both the typhoid and the brucella. the non-specific cases of urinary tract following urinary tract infection is relatively less common. Tuberculosis used to be common in the past, but now we can see sporadic cases from now and then. So we have to be aware of the presence of tuberculosis still. I would like to thank Professor Mamdouh for this presentation, and we proceed now for any questions which are mentioned. تفضل يا دكتور أشرف. لا مؤاخذة يا بيه.
في بعض الأسئلة الدكتور إبراهيم قمر بيقول in type A we go for stabilization even without neurological deficit as in A2, 3 and 4. والسؤال الثاني what is the rule of CT guided aspiration of epidural abscess with or without neurological deficit.
stabilization في type A يعني ال conservative treatment is the first choice of treatment here with stabilization with lumbar support orthosis او بلاستر جاكيت. يعني الحقيقه بيتحسن ومش محتاج ان انا اعمل فيكسيشن في حالات كتير قوي في تايب A كتير جدا يعني. انما طبعا فكره الهاي ديماند بيشنت واللي عايزين يتحركوا بسرعه ونوت توليريت ذا اورثوزس اور بلاستر جاكيت ممكن اعمل لهم فيكسيشن، لكن هو ناس كتير قوي بتخف بالكاس والانتيبيوتيك.
I would like to ask Professor ممدوح الحقيقه لو عنده answer الحالات اللي بتعمل لها external fixation with spondylitis.
ايوه.
والحالات اللي بتعمل لها internal fixation spanning internal fixation with spondylitis. The infection rate of the external fixation or internal fixation devices كم في المية؟
هو الفيكسيشن بيتعمل في تايب A البيركوتينيوس ده بيعتبر انترنال فيكسيتور في الاخر، هو فور سبورت مش الايم بتاعه يعني تو ريليف بين. الفيكسيشن بيحسن الريسبونس تو ميديكال تريتمنت. ففكره الاكسترنال فيكسيتور انت هتقصد حضرتك ان اركب اكسترنال فيكسيتور يعني
ما بيتركب في اكسترنال فيكسيتور لللمبر سباين. وانا كنت عملت في اكسترنال
انا عارف ان حضرتك عملت،
بس هو طبعا مشكلته انه بينترفير من ان العيان ينام على ظهره، فدي مشكله كبيره يعني. الانترنال فيكسيشن
هي يعني ريبليس بيركوتينيال فيكسيشن دلوقتي، يعني هو البيركوتينيوس حاجه شبيهه قوي بالاكسترنال فيكسيتور، بس يعني بتبقى كان بي توليريتد ذان ذا اكسترنال فيكسيتور. اتفضل يا باشا.
هو الدكتور هشام هيكلمنا على البيركوتينيوس ان شاء الله.
مستنيين بقى.
في سؤال من الدكتور عمرو مهدي: Is there any difference in management protocol in pediatric patients؟
هو برضه نفس الكلام في الادلتس، نفس الكلام، لكن في الاطفال هي الفكره في الدياجنوزس، الايرلي دياجنوزس. لو نوجيكال ديتوريشن او ديفيسيت قليل قوي في الاطفال، هو المشكله كلها في البين. انما نفس يعني اللاينز اوف تريتمنت واحده. هي الفكره ان انا ابتدي برضو بالكونزرفتيف والسبورت زي الكبار بالظبط، لكن انا اخد بالي قوي من اللوجيكال ديفيسيت واخد بالي من الايرلي دايجنوز عشان ما يحصلش الايرلي لوزز في الاطفال ويعمل لهم ديفورميتي بيرمننت.
احب اقول حاجه برضه،
لكن المانجمنت.
دكتور اشرف.
ايوه اتفضل.
اسمح لي اقول حاجه صغيره.
اتفضل يا فندم.
في حاله في الاطفال بتحصل ما هياش انفكشن للسباين ولكنها softening of the ligaments of the spine. اسمها جريزل ديزيز. لما الاطفال بيجي لهم upper sore throat او tonsillitis او inflammation of the pharynx، الانفكشن دي بتعمل في الاطفال، في بعض الاطفال softening of the ligaments of the cervical spine.
Yes.
which manifests by pain and inability to move the cervical region. والتريتمنت بتاعها الحقيقه مفيش affection of the spine itself، ممكن يكون في mild subluxation او laxity في الجوينتس نتيجه عن ال softening ligaments، support by collar and antibiotics to treat the sore throat. فدي ما هياش infective spondylitis ولا ديسكايتس، دي حاجه بتحصل في الاطفال من الابر في الريسبيراتوري تراكت انفكشن او السور ثروت في بعض الحالات. بس يا بيه شكرا.
نبدأ مع الشيخ.
في حد في اسئله؟